Welcome to the deep dive. Today we're jumping straight into chronic obstructive pulmonary disease. COPD.
Yeah, it affects so many people, but it can seem quite complex.
Exactly. So think of this as us pulling out the absolute must-knows from a load of revision notes, making it easy to grasp.
Our mission, basically, is a clear, concise rundown, stuff that's useful for recall, for understanding the core of COPD.
Okay, so we'll cover the definition, causes, risks, how it messes with the body.
Diagnosis, the stages, management, those flare-ups, complications, and, the general outlook.
Let's do it. So definition first. What actually is COPD in simple terms?
Okay, so COPD is a chronic, long-term lung disease. The main issue is persistent airflow limitation. Breathing out gets difficult.
And it doesn't really go away.
No, it's typically progressive, sadly. And it involves increased inflammation in the lungs, usually triggered by irritants.
Ah, the irritants. I guess we know the main one.
Tobacco smoke, absolutely number one. But you've also got things like workplace exposures, dusts, fumes, and general air pollution playing a part.
It sounds pretty significant globally.
Oh, it is. A major cause of illness and death worldwide.
Yeah.
And it really impacts quality of life. Think constant shortness of breath, a chronic cough.
Grim. And for smokers.
The most crucial thing, stopping smoking. It's the best way to slow down the disease getting worse. Really vital message.
Right. You mentioned an airflow limitation. How is that actually measured? How do doctors nail the diagnosis?
The key test is spirometry. It measures lung function. Specifically, we look at the FEV₁, FEVC ratio.
Okay, break that down. FEV1 and FVC.
Sure. FEV1 is the volume of air you can force out in the first second of a hard exhale. FVC is the total volume you can breathe out after a full breath in.
And for COPD?
In COPD, that ratio, FEV1 divided by FVC, is less than 0.7, even after they've used a bronchodilator medicine to try and open the airways up.
So the airways are sort of persistently narrowed.
Exactly. That's the hallmark. And we also talk about exacerbation.
Well, we have flare-ups. Right.
Precisely. Those are times when the usual symptoms suddenly get much worse. Might need different meds, maybe even hospitalization.
Okay, let's dig into the causes, the etiology. Smoking's the main culprit.
Dominant, yeah. But not the only one. Think about occupational stuff, dusts, chemicals, fumes. That's a big one for some people.
And genetics.
Yes. There's a genetic condition called alpha-1 antitrypsin deficiency. Less common, but important. Also, past respiratory infections can contribute.
Wow.
And air pollution, as we mentioned.
What about asthma? Is there overlap?
Sometimes, yeah. There's something called asthma COPD overlap syndrome, or ACS. It's not perfectly defined, but it's recognized, a mix of features.
And those exacerbations, the flare-ups, what usually sets them off?
Often infections. Viruses are really common. Triggers things like the common cold virus, flu, RSV. Viral ones often seem to cause more severe episodes, actually.
Makes sense. Bacteria, too.
Yep. Bacterial infections can trigger them as well. Things like strep pneumonia, Haemophilus influenza, the usual suspects.
And pollution again.
Yes. Pollutants like nitrogen dioxide, particulates, sulfur dioxide. They can definitely worsen things and trigger an exacerbation.
Got it. So moving on to risk factors. Who's most likely to get COPD? Can we list them out?
Sure. Smoking is top, current, or past. Then occupational exposure to those lung irritants.
Family history.
Definitely, especially if there's alpha-1 antitrypsin deficiency in the family. Also, frequent respiratory infections, particularly in childhood.
Age is a factor too, right?
Yes, it's usually diagnosed in people over 40. Prolonged exposure to air pollution, as we keep saying.
Anything else?
Developmental factors like being born prematurely or having a low birth weight.
Yeah.
Asthma is a risk factor. Lower socioeconomic status seems to be linked. And even HIV.
Okay, quite a list. So inside the lungs, what's the step-by-step process, the pathophysiology?
Well, you breathe in these harmful particles or gases, especially from smoke. This kicks off chronic inflammation in the airways.
Right, the body's defense system reacting.
Exactly. But it's an ongoing damaging reaction here. This inflammation leads to more mucus being produced and also causes structural changes in the airway walls. They sort of remodel.
Remodel how?
They can thicken, become less elastic. The end result is narrower airways, more resistance to airflow. Basically, it gets harder to breathe, causing those COPD symptoms.
It's like trying to breathe through a narrower straw.
A good analogy, yeah. And one that gets progressively narrower over time.
Now, COPD has some classic symptoms, but could other things look similar? What about differential diagnoses?
Oh, definitely. You got to think about other conditions causing breathlessness or cough. Asthma is a big one. But the airflow limitation in asthma is usually reversible.
What else?
Bronchiectasis that often involves lots of sputum and recurrent infections. Acute things like pneumonia or a pneumothorax, a collapsed lung.
Heart problems.
Absolutely. Congestive heart failure can cause shortness of breath, pulmonary embolism, a blood clot in the lung. Even lung cancer needs to be considered.
Any others?
Upper airway obstruction, fluid around the lung called pleural effusion, maybe recurrent aspiration, even just a rib fracture making breathing painful. Lots to rule out.
Okay. Let's zoom in on the UK. What's the picture here, epidemiologically speaking?
Well, estimates suggest around 1.2 million people are affected in the UK. But many might be undiagnosed.
Really? Undiagnosed?
Yeah, especially in earlier stages. We see about 115,000 new diagnoses each year, mostly in people over 40. And there's a clear link with deprivation. It's more common in poorer areas.
And its impact.
Globally, it's huge, the fourth leading cause of death. And it often travels with friends. Unfortunately, comorbidities like heart disease, lung cancer, osteoporosis, depression are common.
Right. So pulling that together, what's the typical clinical presentation? What signs and symptoms shout COPD?
The classic trio: chronic cough, often productive with sputum, and dyspnea, that's shortness of breath. And crucially, these tend to develop and worsen over years.
Wheezing too.
Yes, wheezing is common. Other things you might see are chest tightness, fatigue, maybe some weight loss, and those recurrent chest infections.
And as it gets worse.
In advanced stages, yeah, you see significant limits on activity, a real hit to quality of life.
So suspicion is high if someone, say, over 40, smokes, and has a worsening cough or breathlessness.
Exactly. That's the classic picture that should trigger investigation. But remember, for a formal diagnosis, you need that spirometry confirmation of irreversible airflow obstruction.
What might you actually see on examination? Any clinical signs?
You might notice tachypnea, fast breathing, prolonged expiration taking longer to breathe out, maybe a barrel chest appearance over time, using accessory muscles in the neck and shoulders to help breathe.
Baby sounds.
You might hear wheeze, obviously, sometimes crackles or crepitations at the lung bases. And in severe cases, signs of right heart failure, what we call cor pulmonale, like swollen ankles or raised neck veins.
We mentioned other causes besides smoking. Any specific occupational ones?
Yeah, things like exposure to cadmium fumes or coal dust are known causes. And the genetic one is that alpha-1 antitrypsin deficiency.
Okay. And back to those exacerbations, what does that look like symptom-wise?
It's usually a definite worsening. Increased breathlessness is key. More coughing, more sputum, and it might become more yellow or green purulent.
Other signs?
Often upper airway symptoms like a cold or sore throat beforehand, increased wheeze or chest tightness, feeling generally unwell malaise, finding exercise harder, sometimes fluid retention, more fatigue.
And in really bad flare-ups?
You can see marked respiratory distress, gasping for breath, very fast breathing, maybe acute confusion, increased cyanosis, that bluish tinge, more swelling. Some patients might develop respiratory failure needing support, like non-invasive ventilation or NIV.
Okay, so if COPD is suspected, what are the key investigations? What tests get ordered?
Spirometry is number one to confirm the airflow obstruction, that FE1-FVC ratio, less than 0.7 post-bronchodilator. That also helps stage severity based on the FEV1 percentage predicted.
What else?
A chest x-ray. It's not really for diagnosing COPD itself, but crucial to rule out other things like lung cancer or heart failure. It might show signs like hyperinflation or a flattened diaphragm in established COPD.
Oxygen levels.
Essential. Pulse oximetry for oxygen saturation, and arterial blood gas analysis, if needed, especially if they're quite unwell or might need oxygen therapy. Tells us oxygen and CO2 levels.
Blood tests.
Yep, a full blood count. Maybe check alpha-1 antitrypsin levels if they're young or have a family history. BMI is important too. Other tests depending on suspected comorbidities.
And the heart.
ECG and maybe an echocardiogram are useful, again looking for heart-related comorbidities or differential diagnoses, especially ruling in or out cor pulmonale.
Any others?
If someone's on the medication theophylline, you check their levels. But those are the main ones. Think S-corba maybe. Spirometry, CXR, O2 blood gas, regular blood's alpha-1, ECG-co.
Nice. Ascorba. Okay, so once diagnosed, how do you grade how bad it is? The severity staging.
We mainly use the FEV1 measurement from spirometry after the bronchodilator. Remember, the FEV1-FVC ratio has to be below 0.7 for all stages.
So what are the stages based on FEV1?
Stage 1 is mild, with FEV1 80% or more predicted, though you still need symptoms for the diagnosis. Stage 2 is moderate, FEV1 between 50 and 79%.
And worse.
Stage 3 is severe, FEV1 between 30 and 49%. And stage 4 is very severe, FEV1 less than 30% are predicted.
Is FEV1 the only way severity is assessed?
No, we also look at symptoms, particularly breathlessness, using the MRC dyspnea scale. It goes from grade 1, breathless only on strenuous exercise, up to grade 5.
Grade 5 being.
Too breathless to leave the house, or breathless when dressing or undressing. It gives a really good idea of functional impact.
Important point. Can you rely on these tests during a flare-up?
No. Lung function tests aren't reliable during an exacerbation. Assessment then is much more clinical, and sputum samples aren't usually needed in primary care unless things aren't getting better.
Right. So the big one, management. What can be done? Let's start with non-drug approaches.
Top of the list, always. Smoking cessation is the only thing proven to significantly slow disease progression. Absolutely critical.
What else helps?
Pulmonary rehabilitation. This program of exercise and education really improves symptoms and quality of life, especially for those with MRC grade 3 breathlessness or more.
Just general activity.
Yep, regular physical activity is encouraged for everyone who can manage it, improves well-being. Vaccinations are key too. Annual flu jab, one-off pneumococcal vaccine.
Diet. Surgery.
Some dietary changes might help manage symptoms. Surgery like lung volume reduction or even transplant is an option, but only for very specific, usually severe cases, often younger patients.
Okay, what about medications? Pharmacological management.
Bronchodilators are the mainstay. Usually start with short-acting ones, a SABA, like salbutamol, or a SAMA, like a protropium for symptom relief, as needed.
And if that's not enough?
Then you step up to long-acting bronchodilators, a LABA or a LAMA, or sometimes both combined. These are taken regularly.
What about inhaled steroids?
Inhaled corticosteroids, or ICS, are generally added if the person has features suggesting asthma overlap, or if they respond well to a trial of steroids, often indicated by frequent exacerbations despite LAMA therapy. Sometimes you end up on triple therapy, LAMA, LABA, and ICS, all in one inhaler.
Any other drugs?
Oral theophylline is sometimes used if inhaled therapies aren't cutting it or can't be used. For some patients with frequent exacerbations, prophylactic antibiotics like azithromycin might be considered carefully.
Mucus problems.
Mucolytics, like carbocysteine, can be tried if someone has a chronic productive cough, and only continued if they actually find it helps.
And that heart complication, cor pulmonale.
If there's fluid overload from right heart failure, loop diuretics are used. Long-term oxygen therapy might be needed if they meet the criteria. ACE inhibitors and similar drugs aren't generally recommended specifically for the cor pulmonale itself.
What interventions actually improve survival in stable COPD?
3 key things. Smoking cessation, definitely. Long-term oxygen therapy for those who are eligible based on blood gases. And in selected patients, lung volume reduction surgery.
And managing those acute exacerbations, the flare-ups.
You generally increase the dose and frequency of their short-acting bronchodilators. A short course of oral corticosteroids is usually given like prednisolone, 30 milligrams daily for 5 days.
Antibiotics?
Yes. Typically given if the sputum has become more purulent or if there are signs of pneumonia. Common choices are amoxicillin or doxycycline or clarithromycin if allergic to penicillin.
Okay. Looking ahead, what's the prognosis generally like for someone with COPD?
It really varies depending on the severity, their FEV₁, how many exacerbations they have, smoking status, other health problems.
But are there general figures?
Well, broadly, 5-year survival rates might range from around 78% for mild COPD down to maybe 30% for very severe disease. But again, lots of individual variation.
And those exacerbations really matter for prognosis.
Hugely. Each moderate or severe exacerbation can lead to an irreversible decline in lung function and increases the risk of death. So prevention is key.
How do you prevent or reduce exacerbations?
Smoking cessation is number 1 again. Reducing other risk factors. Getting those vaccinations. Pulmonary rehab helps. Making sure other health problems are well managed. Sometimes those continuous prophylactic antibiotics used cautiously.
And minimizing the impact when they do happen.
Having a good self-management plan is vital. Prompt treatment with steroids and antibiotics when needed. Using NIV for respiratory failure if appropriate. Schemes like hospital at home can sometimes manage exacerbations out of hospital.
Finally, what are the main complications we need to be aware of? What can go wrong down the line?
Well, the frequent exacerbations themselves are a major complication. Chronic low oxygen levels hypoxemia can lead to pulmonary hypertension, straining the right side of the heart, potentially causing cor pulmonale.
Other things.
Risk of pneumothorax or collapsed lung, respiratory failure, obviously, heart rhythm problems like atrial fibrillation, increased susceptibility to infections like pneumonia, sometimes secondary polycythemia where the body makes too many red blood cells due to low oxygen, and depression is common too.
So the goal of management is really to prevent these as much as possible.
Absolutely. Control symptoms, reduce exacerbations, slow progression, and minimize those complications to improve both quality and length of life.
This has been a really packed deep dive into COPD. Super helpful. What are the absolute key takeaways?
Okay, COPD, progressive lung disease mainly from smoking, causes irreversible airflow limitation. Key symptoms: chronic cough, sputum, breathlessness. Diagnosis: spirometry showing FEV1, FVC 0.7.
And med.
Focuses on stopping smoking, pulmonary rehab, vaccinations, and inhaled bronchodilators. Preventing those exacerbations is absolutely crucial for the long-term outlook.
Fantastic summary. If you listening want to test your knowledge on COPD or dive into other high-yield topics for exams like the MSRA,
Then definitely check out passthemsra.com, and there's also freemder.com for, well, free resources.
great stuff. Thanks for joining us for this deep dive on COPD. Hopefully that's made it a bit clearer and easier to recall.